Welcome back, Focus Learners, to another explainer. We take these complex medical frameworks and translate them into something beautifully simple. And today, today is a really special one. We're diving into Lesson 9 of our Evidence-Based Medicine for Techies course, keeping that Socratic Vibrown spirit alive. Think of this as the ultimate capstone. Over the last few lessons, we've unpacked a ton, everything from spotting fake news to totally breaking down statistical p-values. But look, theory is just theory until it actually gets deployed, right? So today, we're putting it all together. We're going to run a full end-to-end clinical debug on a single patient case. Let's call our patient Arthur. He's an 80-year-old retired systems engineer. He's got a history of heart disease, and right now he's presenting with severe acute lower back pain. We're taking Arthur from his very first presentation all the way to a final medical decision.
Okay, let's dive into our system pipeline roadmap for today's clinical debugging session. 1. Meet the patient. 2. Ask the right question. 3. Search the evidence. 4. Critically appraise the data. And 5. Make the final clinical decision.
Let's transition right into phase 1, meet the patient. This sequence of 5 steps, it functions exactly like a data pipeline. I mean, you literally can't just jump straight to deploying code without writing it, testing it, and reviewing it first, right? Same thing here. But you have to remember the core philosophy of evidence-based medicine. The process always starts with the patient at the absolute center. We aren't just out here blindly chasing a shiny new p-value. We're trying to solve a real-world problem for a real human being sitting right in front of us. We take our initial system logs, which are the patient's raw symptoms, we process them into a query, run that query against a database, stress test the results, and then finally push to production with a clinical decision. Bottom line, before you just type symptoms into WebMD and assume the whole system is melting down, you've got to follow the pipeline.
So our pipeline kicks off by gathering the system logs, which, in the medical world, are known as SOAP notes. This is your subjective and objective history, the physical exam, and the initial assessment. For Arthur today, these SOAP notes are our vital bug report. They tell us exactly what's crashing, in this case, his acute lower back pain. And they also tell us what baseline hardware we're actually working with. We know his age is 80, and we know his history includes heart disease. Without this highly accurate bug report, honestly, we can't possibly know what we're trying to safely fix.
Moving right along to phase 2, asking the right question.
Once we've got our bug report in hand, we have to translate this kind of vague clinical worry into a highly structured, executable query. And we do this using the PICO framework, P-I-C-O. It stands for Patient, Intervention, Comparison, and Outcome. Think of this acronym as your ultimate clinical search schema, okay? For our retired engineer Arthur, the patient is an 80-year-old male with heart disease and back pain. The intervention we might be curious about could be a strong anti-inflammatory drug, an NSAID. The comparison here is standard physical therapy, and the exact outcome we want to see is pain reduction without triggering a cardiac event. It's basically how we parse a massive, super messy medical database into something we can actually search. And this brilliantly illustrates why that structure is absolutely crucial. A vague clinical worry, like, hey, should I give Arthur this painkiller for his back, is virtually unsearchable. Seriously, you'll just get millions of irrelevant hits. But organizing Arthur's specific symptoms and risks into that strict PICO format completely changes our ability to find actionable data. It takes this generalized anxiety about a patient's health and transforms it into a targeted, systematic query that a database like PubMed can actually understand.
All right, let's execute that query in phase 3, searching the evidence. Armed with our perfectly structured PICO query for Arthur, we go ahead and execute our search to find the right clinical trials. Specifically, we want randomized controlled trials, or RCTs, which, as we know, are the ultimate medical A/B tests. Now, we don't have to do this entirely from scratch on our own anymore. We can actually introduce a large language model as our research assistant. The AI is fantastic at drafting the search strategy, formulating those exact PICO questions, and even screening through abstracts. But listen closely, because there is one hard, unbreakable rule in LLM-assisted evidence-based medicine. The AI can draft the search strategy, sure, but the human clinician must verify every single citation. The LLM is just a co-pilot. It is not the captain.
Okay, so our search yields an A/B test. Awesome. We found a randomized controlled trial evaluating anti-inflammatory drugs for back pain. Perfect. So we can just hand Arthur a prescription and call it a day, right? Well, hold on a second. Is the data in that trial actually valid? Is this A/B test genuinely robust enough to base a real-life clinical decision on?
That brings us right into phase 4, critically appraising the data.
We have to rigorously evaluate the source code of the clinical trial we've just uncovered. We are definitely not just taking the author's abstract at face value here. We're opening up the methodology and we're actively hunting for bugs. To critically appraise an RCT, we use a very strict three-question framework. First up, validity. Was the trial designed properly, or is it just totally full of confounding variables and p-hacking? Second, results. What are the actual numbers? And third, applicability. Does this trial actually matter for our specific situation? Think of this framework as our ultimate stress test.
Let's zoom in on that third point, applicability. We literally must verify if our specific patient actually matches the population that was tested in the trial. Imagine if the trial's average participant for this back pain medication was a 25-year-old healthy athlete. Arthur is an 80-year-old with a history of heart disease. If that's the case, the A/B test results are completely irrelevant to us. We're checking to ensure the data maps correctly to the real-world hardware we're treating today. Treating Arthur based on data from a 25-year-old, that is a critical system error. Now, what's really interesting here is how incredibly counterintuitive medical statistics can actually be. When we dig deep into the results section of our appraisal, we might see a big flashy headline claiming a massive 40% risk reduction for back pain using this specific drug. I mean, that sounds incredible, right? But when you sit down and work out the absolute numbers by hand, you often find that this actually translates to a number needed to treat, or NNT, of 25. That means you have to treat 25 separate people with this intervention just for one single person to actually benefit from it. The other 24 people, they get absolutely no pain relief, but they still take on all the cardiac risks of the medication. Crazy, right?
And the absolutely crucial point here is that you have to do the math yourself. Look, while your LLM Copilot can instantly summarize calculations for you, like the absolute risk reduction or the number needed to treat, you still have to stress test your own appraisal. The AI calculates, but you must verify every single number against the original clinical source text just to ensure the math isn't totally hallucinated. Finally, we arrive at phase 5, the final clinical decision.
So let's review. We have our system logs for Arthur. We've got our PICO query, our search results, and our critical appraisal of both the math and the validity. Now we have to synthesize everything into a definitive ship decision. Are we going to treat him with this intervention or not? Often, in this stage, you'll consult broad clinical guidelines. And you can think of these guidelines kind of like test coverage in software development. They basically show you what works best for the vast majority of standard cases. But remember, guidelines are just the baseline. You still have to reconcile that guideline with Arthur, who, with his specific heart condition, might not fit the trial average at all. The final, ultimate choice, that ship decision, requires taking that broad test coverage and carefully applying it to the very unique parameters of the individual sitting right in front of you. And that really leads us to the ultimate goal of the Vi-Brown's philosophy and this entire capstone exercise. As the core tenet tells us, evidence-based medicine isn't about blind faith in data, but about marrying the best evidence with a specific patient sitting in front of you. Data is a fantastic tool, but it is not a dictator. It requires a human mind to interpret the validity, to weigh the risks, and to apply it all with empathy and precision.
We've successfully taken Arthur from a raw symptom bug report all the way through to a synthesized, data-backed clinical ship decision. You now have the first principles framework to evaluate A/B tests, calculate true risk, and responsibly use AI to accelerate your own research. So here's my final question for you. Armed with this brand new pipeline, how will you debug your next complex clinical problem? Keep questioning, keep verifying, and I'll see you in the next explainer.